Welcome and thank you for joining us today. This telehealth series is presented by the Now New Mexico Quality Improvement Initiative. This initiative focuses on optimizing care for neonates at risk for opiate withdrawal syndrome. This 12-part curriculum is designed to give providers, nurses, care coordinators, and community members content-specific training and education with opportunities for care consultations around this focus. And today we have two speakers with us. Our first speaker is Dr. Heather Pratt-Chavez. She's an associate professor of pediatrics at the University of New Mexico, and she is an expert in the care of neonates with opiate exposure and withdrawal symptoms. And we also have with us Dr. Andrew Shih. He also has his Master's of Public Health and is the founder of the Family Options Caring Understanding Solutions program that has created a system of care of infants and families affected by prenatal and familial substance abuse disorders. He directs the Institute for Resilience, Health, and Justice at the University of New Mexico's Health Sciences Center, and he is dedicated to the emotional, intellectual, and social development of young children, especially those affected by adverse childhood experiences. Thank you for joining us today.
Great, thank you.
Thanks for having us. And thanks, Andy, for coming today to talk. When I go out to community hospitals, almost all of the providers at all levels ask me about how to best plan for long-term care of families and babies who have substance use disorder exposure. So I really appreciate you coming to talk about this topic today.
It's a real pleasure being here. And I think that the real important message is that if the care is organized correctly, we're talking about a very important process of interdisciplinary care that can ameliorate many of the factors related to prenatal drug use, drug exposure, and support the family going forward to improve the health outcomes of the mother and parents simultaneously. So the title of our talk is Long-Term Follow-Up and Care for Families Affected by Opiate Substance Use Disorder, the Focus Clinic Model. And you mentioned the Family Options Caring Understanding Solutions, and that's the acronym. FOCUS is the acronym that we created for that program. The objectives for our presentation, at the end of this presentation, the attendees will review identifications of families at risk, anticipate the prevalence of children at risk for substance exposure, explore potential interventions, and appraise the focused family medical home model, that medical home model that provides care for two generations simultaneously. Dr. Pratt-Chavez and I do clinic together, and we get to see some of the progress that families make as we're seeing them in focus. The first place to start is with a metaphor. Three friends, and let's call them dedicated health professionals, approach a wide, beautiful river, sort of like the Rio Grande in the spring. And the idyllic scene is shattered by the cries of a small child in the water, flailing his arms while struggling to stay afloat. He's fast approaching the waterfall. And this metaphor is taken from a book by Rishi Machanda, The Upstream Doctors, Medical Innovators Track Sickness to its Source, from TED Books. And this metaphor needs to be applied specifically to the issues of primary care in the United States and the feeling that primary care providers have taking care of families affected by substance use disorder. It's a lot like trying to paddle upstream without a paddle. However, there are things that can be done and important stories to tell that to make this process of care much better. So we'll start with a case study, description of a family at the start of Focus Services in 2010, a watershed moment in our metaphor about the river. So we'll start with a 17-year-old mother named Ava who was sexually assaulted, resulting in her pregnancy. At the time of her pregnancy identification, she had a 2-year history of methamphetamine use. Her pregnancy resulted in the delivery of baby Lamarcus at 25 weeks, and because he was premature and had prenatal drug exposure, he stayed in the NICU for 5 months and had problems including bleeding in the brain and chronic lung disease. Ava had come to Albuquerque and was living with her boyfriend's family, but her boyfriend was out was in prison out of state. And given the circumstance of premature birth, the prenatal drug exposure, the father being in prison, social services was called from the hospital and conducted an investigation of the family. It's a tough way to start. And at the time that we met Ava and Lamarcus, we identified their little family boat entering some rough rapids. So discharged from the NICU, we learned that Ava in the boyfriend's home was being exploited. Basically, she's being used as a servant for the family, was not being paid. There was no availability of substance use treatment services for teens that was easy for her to access. If she were going to go to treatment, she needed help with childcare, and the boyfriend's family wasn't really willing to do that. The boyfriend did not look like the father of the baby because the baby had been conceived as a result of sexual assault. And finally, Ava needed help with employment, in part so that she could support herself and Lamarcus, but also to get out of the very difficult family situation and begin to develop an independent life for herself. She had depression, not surprisingly. It could have been postpartum depression, but it could also be endogenous depression of mental illness that's common for women who have drug use in pregnancy. And looking at Lamarcus's life, we identified him as starting with a number of adversities or a number of adverse childhood experiences. Well, what are the implications for pregnant women and the brain development of fetuses? So we know that the various drugs that are used during pregnancy, both illegal and legal, will pass through the placenta and will cross the blood-brain barrier of the fetus and create effects on the fetal brain. These are small molecular weight drugs, getting kind of into a wonky area. They have a molecular weight less than 500 Daltons. For example, methamphetamine is small, 149. Buprenorphine is a little bigger at 467 Daltons. Tetrahydrocannabinol, the active ingredient, of course, in marijuana, has a molecular weight of 314 Daltons. Ethanol is so small as a molecular substance that it can cross membranes, most human membranes, and achieve a concentration on both sides of membranes in about 20 minutes. That's why it's so dangerous if it's ingested rapidly. And it has a very rapid effect on potential structures in the baby's brain. Use in the first trimester, that is the first 13 weeks of pregnancy, is particularly threatening for brain structures for the developing fetus. So this slide looks at, in a graphic way, the periods of time in fetal development that can be most impacted by week of gestation. The critical period occurs in the first, say 4 to 16 weeks. And so substance use during that period of time in particular can have a very significant impact in a sensitive window of brain development, but more importantly, the chemical neuroreceptor systems that control human brains as well as the brains of many species. These neuroreceptors begin to appear in brain structures at 11 to 16 weeks of gestation, often so early that women who are using substances don't know they're pregnant. There are impacts on a number of these systems, including enkephalin, which is an opioid growth factor, which then regulates growth of the brain and other fetal organs, affects the dopamine transporter, both directly as methamphetamine does, but also in terms of regulatory impacts created by use of opioids or cannabinoids. Cannabinoids affect this is a long expression, gamma aminobutyric acid, but we call it GABA or GABA because it's hard to say that long term more than once a day, the glutamate systems and serotonin systems. So all these very, very important chemical neuroreceptor systems in the brain experience impact of substance use, particularly early in pregnancy. The second and third trimester use affects synaptic complexity, which is a way of saying that as fetal brain neurons grow and begin to make connections, the presence of any of these drugs reduces the likelihood that these synapses will form normally and regulate normally. Now, there are a number of research questions, and we wanted to look particularly at birth outcomes as we took care of women and babies affected by prenatal drug use. So in the research studies that we conducted in early work in a precursor program before the focus program, we wanted to look at birth outcomes. And so the study looked at women who had low income status. And I want to point out that in almost all the studies of long-term follow-up of infants or kids affected by drug use, they're almost always focused on low income populations. We extracted data from the medical record on infant weight, length, and head size, and these measures as we followed them over time. And because they were so highly intercorrelated, we constructed a composite measure. In our study, we compared women using heroin and cocaine with women not using heroin and cocaine during pregnancy. And the primary questions were two. Does prenatal care affect the birth parameters of infants born to both groups of women? And does incorporation of a comprehensive drug treatment program, such as the Milagro program, into the prenatal program improve the birth parameters of infants born to women using heroin and cocaine? Now, that says nothing about whether it improves the lives of the women during their prenatal course. If they enter drug treatment, it says nothing about how their mental health is doing. It's really asking, does drug treatment increase the birth outcomes of the infant? Right. And the study group included 505 mother and infant pairs in care from 1990 to 1992. One group of women included the women in the Milagro program who received comprehensive prenatal care and obstetrical care, including drug treatment. And then a group of women who used cocaine, heroin, or methadone who received standard prenatal care. And that meant no documented specific drug treatment during their prenatal care, who then enrolled in most hospitals after the baby was born. And we looked at then 198 women without history of alcohol, tobacco, and drug use to try to understand the impact. So this is a simplification, but a very instructive graph. On the left-hand side axis is the composite infant birth parameters. And just for the sake of simplicity, we went from small to large in terms of infant birth parameters. And on the horizontal axis is the amount of prenatal care, ranging from low prenatal care to high prenatal care. The top line, the yellow line, shows what happened for women, the 198 or so women whose pregnancies we followed, who had varying levels of prenatal care but no substance use. In our population, the infant birth parameter was quite good, but it didn't matter how much prenatal care was documented. Their infants had pretty normal birth weights, lengths, and head circumferences. However, for the women who had substance exposure during pregnancy, 127 in Milagro and 180 infants referred to Los Pasos, the impact of prenatal care made a significant difference. The more prenatal care a woman had with drug use, the greater likelihood that they would deliver an infant closer to term and a better size, particularly better head size. So what we concluded from this research study was that more prenatal care improved birth outcomes. It was not related to specialized obstetrical services, so it didn't need to invoke maternal fetal medicine unless there were other medical complications during pregnancy. Full drug treatment, as was currently practiced in 1990 and 1992, was not essential to improve outcomes of the infants. Now, there's some possible biasing factors for higher levels of prenatal care. So a small number of women had completed the Milagro Residential Treatment Center that we had started at that point. So they were in residence and seen more often. So the women who had a greater commitment to pregnancy potentially obtained more prenatal care. So it may not have been prenatal care itself, but really that the individual woman wanted to see a good pregnancy outcome. Some women might have had better transportation, were able to come in prenatal care visits easier. And then, of course, with any use of illicit drugs, it's very hard to determine the intensity of the drug use, that is, how often somebody uses it, how much they use it, and then the purity of the various drugs that are used. All those things are unknowns. So there's potential biasing factors. Could have been that women who had more prenatal care had access to drugs that were less potent. The use of heroin and cocaine during pregnancy did not reduce attending more prenatal care visits. So even though women were using, they still came to prenatal care visits. And the fact that providers saw them and provided care seemed to have made a difference. Drug treatment in and of itself may set the stage for early childhood care, that is, may set the stage for better child care for infants because the mothers are engaging in drug treatment. Now, this all predated the ability to prescribe buprenorphine from primary care providers. That the current model of care at that time meant that women had to go to drug treatment centers to access methadone and to access counseling.
Andy, I feel like the results of this study are very hopeful for communities that are underserved and have don't have drug rehab, don't have even providers that can provide Suboxone, but have the ability to reach out to moms to engage them in prenatal care. Because what it's showing is that simply engagement with prenatal care can improve birth outcomes, whether or not it's comprehensive. And having a mom who's connected to medical care actually can improve birth outcomes.
You know, Heather, I think that's such a good point, because I think what it is that prenatal care providers who are committed to providing this type of care do is they provide some additional unmeasured quality that makes that engagement happen. Mm-hmm. And whether it's a kind word or it's just the very fact that there's a caring system seems to do a lot to increasing the number of visits as well as improving outcome. So I agree with you completely. I think we don't need to invoke a huge specialty care system or centralized tertiary care models if we can find people in the community in primary care and the supporting systems to do this.
Of course, ideal gold standard of care is the best, but
Absolutely.
when we've got limited resources, it's so nice to know that even just engagement in care can make a difference in birth outcomes.
That's exactly right. Mm-hmm. Clicker. Okay. And we have a little blackout that. Thank you. I think I may have put the computer to sleep. I apologize to the computer. So more discoveries that we found from this evaluation. We thought, of course, that women who were using substances would automatically accept drug treatment. And we found that only 6 of the 180 women in the Los Pasos study during that period of time accessed formal drug treatment. It meant that there were potential barriers to going to drug treatment centers that we hadn't anticipated and needed to be examined. The current system in Albuquerque at that time did create some barriers. There was limited availability of methadone programs in pregnancy, so a lot of the methadone programs didn't want to provide care for pregnant women because of the potential complication of a poor pregnancy outcome. The counseling models, and I think this is still true, are really modeled on a male treatment approach. The original 12-step program was not built for female patients, and to some degree, I think, continues to create barriers. The system struggled to treat women who had dual diagnoses, so chronic depression, bipolar disorder, schizophrenia, and drug treatment. Though that care was not localized in one place. People actually literally had to go to the mental health center for one part of care and to ASAP for the other part of care. And oftentimes providers felt very overwhelmed trying to address both. So what often happened is that women didn't get any care. Women with drug use were frequently not treated until drug treatment was started for their psychiatric health needs. there were no treatment facilities for young, no facilities for young children. So a woman who was going to access drug treatment faced a choice of leaving her young child with somebody who she couldn't rely on to go to treatment, or taking her child with her where the treatment center wasn't prepared to have the child in the facility. We ultimately addressed that in another grant by building a playground outside of ASAP for young children so that they could be there and finding and identifying, hiring child care providers. And finally, most counseling does not recognize the woman who uses substances as a parent. It's as though that relationship with the young child doesn't have any weight in decisions made about being in treatment. So, given that kind of situation in the community, we felt that it would be important to begin to look at ways of creating a medical home approach. There was already a body of literature that documented poorer outcomes for children with prenatal drug exposure. The work done by Dr. Wolds and other people associated with the Brown Child Development Center created the Infant Development Environment and Lifestyle Study, the IDEAL study, IDEAL study, that looked particularly at prenatal methamphetamine exposure. Now, this study was conducted in several locations in the United States and Hawaii and New Zealand. And they selected, and the folks at the Brown Child Development Center have done a really good job at selecting a non-biased comparison group. And their reports have shown that if we look at kids from time of birth to the time they're entering elementary school in New Zealand and other U.S. locations, that we are beginning to understand some longitudinal findings, particularly related to methamphetamine exposure. When they looked at the newborns, the babies were smaller. Their newborn growth parameters were smaller, and particularly their heads tended to be smaller, which implies that brain growth during fetal life was somewhat suppressed compared to babies without exposure. When they looked at the infant's neuromotor capacities, there were some abnormalities, particularly identified as low tone. By age 7.5 years, the cohort of kids who had exposure to methamphetamine had intellectual problems compared to kids who didn't have drug exposure. And it wasn't clear in their studies, looking sort of in the fine print, exactly what elements of their intellectual ability were disturbed. But other studies have shown that some of the major impacts have to do with issues of development of expressive language, which is closely tied to the ability to read, and then socio-emotional behavior, which has to do a lot with regulation. And in the New Zealand cohort, they found behavioral problems with high and complex needs, suggesting that in the school environment and interaction with peers and teachers, that kids were having a lot of behavioral regulation problems. So the Wold study, particularly referring to the work in New Zealand, suggested there were actions that could be taken before reaching the cold face of childcare. By cold face, she meant basically that place in the underground seam where the hard mining had to occur in order to extract the coal, or maybe even thinking about extracting diamonds. And that there's actually work that can be done before you reach that coal face. And that's led us to think about what we view as a two-brain approach to developing care systems. So the theories that we implemented about substance use have been informed by the women who we see for care, and have then resulted in our thoughts about how the service system design should be. As we got to know mothers in the Los Pasos program, which was the predecessor to the Focus program, they reported very high levels of psychological abuse and physical abuse as children. So the homes they grew up in were very difficult and challenging. A great number of women also experienced sexual abuse in childhood, often starting before elementary school. There were significant home environment issues regarding parental alcohol or drug use, parental mental illness. They were living in homes where they saw violence directed against the partners. There was a real lack of support systems for the child, even from their extended family. Many of the women reported multiple attempts at running away from home at early ages. They were moved from household to household, often by relatives who really wanted to do a good job trying to help them, but this instability in their home life created challenges. And then many of the women left formal education as early as 8th grade at like 12 or 13, and were not in the job sector. So these are major life challenges, and they were happening in some sense well before the cold face of delivering a baby. These are things that were occurring in their lives and being observed from multiple different perspectives, but not seeing an intervention model that would work for them. So that their experiences have led us to begin to understand something about what happens to us. Instead of why are you doing that, or how come you're abusing substances, the question now becomes more what happens to us, or what happened in your life. And often the underlying cause of that is a set of concepts that are now being called adverse childhood experiences, or ACEs. This information began from a study conducted by Kaiser Permanente in San Diego County in collaboration with the Centers for Disease Control. The Centers for Disease Control has, as part of its work, a interest in preventing injuries. And they are looking at, from the injury prevention perspective, what can be done to reduce child abuse or physical child abuse. The Kaiser Permanente group is interested in looking at membership in their organization to reduce long-term poor health outcomes, in part to improve people's health, but also in part to decrease costs to the health maintenance organization. This work, published in 1998, refers to the 17,000 plus adults who completed a mailed survey, which was quite lengthy, that preceded their showing up in the Kaiser Permanente preventive health clinics for a full medical evaluation. The people who completed the surveys, on average, were 56 years old, so certainly not little kids or teenagers, but mature adults. They came from an employed, insured population, so in some sense, middle to upper middle class income population. And they were willing to respond to sensitive questions about what happened to them as children. And from that, concepts began to be linked between adverse childhood experiences, health risk behaviors, and disease outcomes. The findings from the Kaiser study were very surprising. The lead author, Dr. Vincent Felitti, who I've had a chance to present with, said that they were astounded to find that of this 17,000 people, more than 10% reported remembering psychological abuse as children. More than 10% had physical abuse. 1 in 5 to 1 in 4 had childhood sexual abuse. 1 in 4 lived with a family member who abused alcohol or drugs. 1 in 4 or 5 lost a biological parent. Not meaning really divorced or separated, but literally the parent just walked out of their life. 1 in 5 lived with a family member who was mentally ill or suicidal. 1 in 8 lived in a home where there was violence directed against a child's mother. And 1 in 20 lived in a home where a family member was imprisoned. Separation or divorce is sometimes included as an adverse child experience, and that occurred in about 23% of the individuals who responded to the survey Kaiser study. And so that data represented what Felitti and people at CDC began to think of as a burden of adverse experiences that people carried forward into their lives, and that then had potential impacts on their health. I don't know if this this next slide doesn't really say it, but literally when they looked at the San Diego Kaiser Permanente population, they found that essentially 2/3 of people in that population had at least one adverse experience, and about 12% had 4 or more adverse experiences. So what they found in this group of people who were middle class, upper middle class, insured, working, was that what had been viewed as a somewhat rare and unusual experience, that of physical abuse or sexual abuse or violence in the home, was actually very, very common. In fact, the majority of people have had adverse childhood experiences, and that finding has been replicated in multiple other studies looking at other populations in the US. Now the implications in the Kaiser study was that if you looked at people who had 4 or more adverse childhood experiences compared to individuals with no adverse experience, so we're talking about 12% with 4 or more compared to about the 33% with no adverse experiences, those with 4 or more adverse experiences had 2 to 10 times greater risk of becoming pregnant as a teen. But it wasn't just the females in the study, the males had a 2 to 10 greater risk of fathering a child as a teen. So the impact on early sexual activity and the risk of unwanted pregnancy was increased for both males and females. A much greater risk of depression, a much greater risk of early initiation of tobacco use and smoking, resulting in chronic lung disease, a lack of physical activity throughout the lifespan, which leads to risk of obesity and cardiovascular disease, and then just poor health by self-evaluation, that individuals, as they saw themselves, were less likely to view themselves as healthy. And what wasn't known is what behaviors or adverse experiences as adults had occurred since the time they left childhood that might have an impact. So this was really looking at what happened before age 18 for this population. A graphical way of looking at this is to look at an adverse childhood score of 0 as having a relative risk of 1.0. And this table, while complicated, shows a very important pattern. If you look at each increased level of adverse childhood experience, not number of events, but each increased type of adverse experience, the risk for these very significant health risk behaviors, alcoholism, intravenous drug use, attempted suicide, begins to go up in what we would think of as a dose response curve. That is, the more different types of adverse experiences a person had, the greater their risk was for any of these complicated problems. So let's go all the way down to 5 or more adverse experiences. And what we see is that attempted suicide goes up 17 times compared to somebody who had no adverse experience. The risk of alcoholism goes up 5 times, and the risk of intravenous drug use goes up 9 times. So the impact of 5 or more different types of adverse experiences on an individual's life resulted in this study of people now in their mid-50s of much greater lifetime risk of very complicated and difficult to treat problems. So let's put this in a clinical picture. We're going to refer to kind of a graphic, what my colleague and friend Dr. Sally Backhofer and I call the layer cake model of life experiences. If we go across the lifespan from birth to death, and we look at individuals who have healthy development, they have a set of childhood experiences that they then build into, let's see if my little clicker works. Oops, okay, wait, oh, there it is. Woo, vanishing. Optimal neurodevelopment. So childhood experiences lead to the ability for the brain to develop, which then leads to the development of social, emotional, and cognitive skills to be able to address the challenges of life, which then leads to the adoption of health behaviors like eating well, exercising, getting enough sleep, which then builds on into a health status that carries people through life. And of course, at the end is the end of life. But this is a strong, healthy, productive life. Whereas an individual who has adverse childhood experiences and has that foundation then has the risk of disrupted neurodevelopment. A lack of the kinds of personal, interpersonal skills, which then lead to social, emotional, and cognitive impairments. And that presence of impairments lead to the adoption of high-risk health behaviors like alcohol use, excessive alcohol use, or drug use, which then leads to disease and disability. And in our state population, the risk of hepatitis C becomes much higher and basically shortens life and early death. And in some studies, that shortening of life may be as much as 12 to 15 years for people who've had multiple adverse experiences compared to somebody who's not had adverse experiences. So a shortened lifespan occurs as a result of the impact of adverse experiences in childhood. So just to backtrack a little bit and talk about the study population, these are insured people living in San Diego County, one of the most pleasant counties in the US and possibly one of the richest counties. They were employed or the dependent of people who were employed. They were answering a lot of questions and some of them quite sensitive. That led us to understanding something about how the connection between ACEs and poor health outcomes might occur. We're always looking for a mechanism to explain why you begin to see these patterns. So what researchers are beginning to identify is the impact of stress. And stress is a type of stress that can affect everybody of all ages, from infants to children to adults. Sometimes parents experience stress because of their children, but certainly not because of these cute little children here, right? Until they start crying in the middle of the night. Okay. I think our little battery maybe starting to go dead here. Anyway, but no problem. So there are three types of stresses. So the Centers for Disease Control identified three types of stresses. I thought maybe there were more, but three's good. There's positive stress, the kind of stress that's routine and short-lived, the kind of stress that's experienced within stable, supportive relationships and promotes healthy development. So it's like getting ready for a final kind of stress. Then there's tolerable stress, the more intense type, the short to moderate duration, that's limited and occurs within supportive relationships, and that type of stress is reparable or compensable. And that would be, for example, the individuals who have been experienced with Hurricane Irma and Hurricane Harvey in the southeastern United States, who have the resources provided to begin to recover and to begin to reestablish their homes. And contrast that with the last type of stress, toxic stress, where stress can result in altered development. And this is the frequent and or sustained type of stress, the kinds of things that occur early in childhood and are not ameliorated, with no buffer of adult support, with no parent who's willing to step in and change the impact of the stress. This type of stress has probable effects on brain development and even affecting the structure and size of important areas of the brain, has impact on other organs, particularly the vascular system, creating risk for high blood pressure. And it dysregulates physiologic stress responses, either creating a persistently high threshold for responding to threats or persistently low threshold. When an individual experiences a threat, there's an amplified impact that can create an overreaction. And this type of toxic stress can result in cognitive impairment. And I would say that the experience of people in the U.S. Virgin Islands or Puerto Rico right now would begin to verge on the toxic stress 5 or 6 weeks after the disaster without any clear path to recovery of their homes and lives. So we have, within the past year, examples of significant types of environmental stress without even talking about stresses in family systems. So these episodes of stress in the toxic stress model become the usual pattern. And so there's persistent activation of the neurophysiology of threat that then resets the homeostatic equilibrium. So individuals who have this kind of experience then begin to think that everything is going to be as it is. And if you're living in a place where there's no water, no electricity, you have no place to live, you're living in shelters, you begin to think that's a new norm. And that can create a lot a lot of persistent sadness. This persistent hyperarousal then results in altered noradrenergic systems. This is the fight or flight response that we all get when we're confronted with a threat. But if that threat persists and continues, we're unable to distinguish normal stresses from the accentuated stress. And we see kids adopting either a strong fight or flight response or persistent dissociation, emotional separation from environment and people around them, which is partly tied to alterations of opioid and dopaminergic neurotransmitter systems, which affect pleasure and reward. So we've kind of come full circle, coming back to the neurotransmitter, neuroreceptor systems that we talked about in developing fetal brain, and now look at them in terms of the older child or individual. Oops. Right. So one of the examples I use is the drive to work every morning. Everybody I know pretty much drives the same way to work every morning, right? In Albuquerque, we know that that's the way that's going to get you there with some margin of error. If you leave 5 minutes late, it's going to avoid the orange barrels. It's going to avoid the traffic slowdowns. That's how we alleviate stress. We drive to work the same way every morning, and it works. But if you couldn't predict that whether your route would be complicated or not, you would begin to have persistent stress, particularly when your supervisor looks at you kind of out of sight of their eye about why you're late. All right, so what other ways does toxic stress affect development? Well, if we think that experiencing stress is part of healthy development and in some sense strengthens the brain and the brain's ability to cope with more challenging situations, toxic stress is on the other end of the spectrum. That presence of toxic stress, such as what happens when kids are in homes and they're having adverse childhood experiences, begins to weaken the architecture of the brain itself. When it's present for a high level for a significant length of time and there's no supportive relationships to help regulate, we begin to see impairment of the development of normal neural connections. There are areas of the brain that are reduced in size that control higher order skills, particularly the prefrontal cortex. Learning, behavior, and memory formation are altered because there are structural impacts on anterior cingulate area of the brain, and the long-term impact are decrements in physical and mental health. And so this set of adverse childhood experiences that the Kaiser and CDC study identified are sources of toxic stress, represent the greatest challenges to children's development. And as we pointed out, when 2/3 of the population in Kaiser experience it, or in a later CDC study published in MMWR, 60% of people in New Mexico experience toxic stress, we can begin to see how what happens in childhood has resounding impact across the lifespan. This is a wonderful schematic that was originally created by Dr. Bruce Perry, looking at levels of the brain. And going from the bottom to the top shows the most primitive part of the brainstem or the hindbrain, and then the diencephalon and cerebellum, and then the limbic system, which is thought to be the midbrain, and finally the cortex. The cortex, which is really that, really there's about 5 millimeters of gray neuronal cells that are the margin of brain development that defines the human species from many other species. And as we go from the more primitive to the more sophisticated or developed, we see that body temperature, heart rate, blood pressure are controlled in the brainstem level and hindbrain, but abstract thought, concrete thought, affiliation and reward systems are controlled in the cortex. And so impacts on the higher functioning parts of the brain will impact those things that are most important to us in terms of success. It also shows that there are 3 main neurotransmitter systems: the dopaminergic, that's DA, then noradrenergic, or NE, and serotonin systems, SER, that are significant, and they are expressed and connect every part of the brain to the hindbrain. Now, when adverse experiences occur, the brainstem has trauma core symptoms, the physiology of PTSD, recurrent nightmares. The next higher level demonstrates depressive and affect symptoms. The next higher level in infants begins to manifest neonatal dysregulation primed by maternal toxic stress. At the next higher level, there are relational difficulties, that inability to read cues correctly and respond to cues correctly between, say, child and parent, or between individuals. And then there's the risk for alcohol and substance abuse that are driven by the limbic system and the sort of rewarding or addressing chronic stress by the use of substances in a repetitive pattern. And then finally, at the cortical level, there are impulsive reactions that are not inhibited well by the frontal cortex. There's triggers for substance use, and there's guilt and shame. So impacts of adverse childhood experiences have the potential to affect every level of the brain. Good. So going back to our original case of Ava and Lamarcus, we begin to think of the two-generation impact of adverse experiences in sort of the layered cake schematic again. So starting with Ava, who had adverse childhood experiences leading to disrupted neural development, leading to impairments, leading to adoption of health risk behaviors, these all feed into the child's life, including brain altered by prenatal exposure to methamphetamine. For Lamarcus, they had potential of causing adverse childhood experiences that then lead to disrupted neural development. The adoption of health risk behaviors by the mother, Ava, contributes to further disrupted neural development, which then leads to social, emotional, and cognitive impairments, leading to the adoption of health risk behaviors. And if nothing's done to interrupt the progression of this layer cake, we arrive at potential early death, disease and disability, and early death for both generations. Oh, there we go. And I apologize. I'm not quite sure I'm having such a flicker problem. I think the computer is, getting overwhelmed by the information. Well, the first year of life for Ava and Lamarcus was quite complicated. This is, we identified they're entering rapids, now they're in fast-moving water. Lamarcus went home on oxygen, and going home on oxygen as a preterm baby implies that there's big risk for long-term lung problems, just chronic health problems. However, Ava kept all of her focus clinic appointments. She took the bus to come to focus with Lamarcus, which, if you're trying to get a young child on the bus, anybody knows that's not an easy thing to do. She allowed our developmental specialists to come into the home. So our home visitor, early intervention visitor, had contact with Ava and Lamarcus in the home. Ava's skills of being a parent were validated. She felt supported. We were able to demonstrate things that would help her do things to help Lamarcus, not only with his health needs, but also his developmental needs. The boyfriend was released from prison in the Southeast. And since this wasn't his child, and he's coming home to this family setting, one of the big questions would be whether he would accept Lamarcus as his child and participate in the child's life. Well, Heather, you mentioned engagement, and I think what we looked at in terms of following kids over some period of time, from the time we looked at their newborn parameters and then followed the cohort, we found that there were several groups that we thought were very interesting. Now, it's hard to follow families at high risk easily over time and to collect complete data. So this represents fairly small numbers. But if we looked at just the physical height of the baby, a measure that's not influenced by overfeeding or underfeeding, it's not influenced by whether the house is too hot or too cold, or has toys or doesn't have toys, and we looked across 2 years, what we found is that in the low to medium engaged, the growth percentiles for height pretty much stayed flat. Wasn't bad, stayed in channel, but in the group that had higher engagement, the physical height parameters actually increased from about 30% to closer to 50%. That is, they moved from a little bit below normal to normal for the population, which means that other things were going on besides just feeding or just genetics to create that outcome. I would point out the same thing was true of head circumference. In fact, there's even more significant for head circumference in terms of brain growth, that the higher engaged populations had better head growth percentiles over the first 2 years. If we looked at maternal report of drug use and looked at the group of people who had low and medium engagement, the numbers of mothers who reported using crack, cocaine, or heroin was around 33% at the time of birth, and over the first year of life dropped to about 20%. So we saw some reduction, which was great. But in the women who were highly engaged, it went from almost half who were using at the time of birth to almost none at the end of the baby's first year of life. So something was going on in terms of the issue of engagement with the baby's care, and the folks who were coming to help with the care of the child and the mother's interest in using drugs. So we looked at what contributed to success. How did mothers become successful? And what we found was, for those who were least successful, there was lack of engagement. They just never connected with anybody on the team. There was a lack of motivation. Now these findings were generated by the independent research group who worked with us. So they're conducting interviews with the women apart from the care they're getting. It's not determined by clinical providers. The women reported that they continued to increase their substance use, they had untreated psychiatric illnesses, they lacked social support, there was chaos in their home, they were unemployed or received public assistance, they had child custody problems. That is, a child went into foster care, or the other partner had custody of the child, and then there was difficulty reestablishing contact, and they had legal problems. However, for those who were most successful, they connected with the program. They, like Ava, allowed the home visitor to come see them. They kept appointments in the medical team. They felt personal motivation. They were able to reduce their substance use or achieve abstinence. They had social support. They began to regulate the home, in part because the home visitor showed them how to create routines for things like when the baby needs to eat, how to put the baby to sleep. Those kinds of transition times that are very challenging for any family. And then they began to find employment or continue their education and access financial resources. So starting with folks who had very complex substance use disorder, what we find here is that it's not like the group who was most successful suddenly were given, won the lottery and had $100,000. Or it wasn't that the least successful didn't have opportunity to engage in services. It was really in part driven by personal characteristics that allowed the ability to build trust and engagement, and then those things resulted in what we would, I think, most of us view as very, very important positives. So to achieve a smoother river, to reduce the risk of capsizing, what we learned are some important lessons, that mothers and many times fathers would make changes for their babies, that this opportunity to be in the child's life created a way of seeing themselves and what they could be that was demonstrated by good cue reading in the home, so they could tell when the baby's hungry, when the baby's tired, and responded appropriately, that they provided basic needs most of the time. I like to think that as parents, what our obligation is to meet our children's needs. We will definitely not meet all their wants, and man, those wants increase over time. If we meet their needs, we're doing really well. That's the part of the definition, I think, of adequate and appropriate parenting. And they kept most of their medical appointments. That is, they felt that their child's health was important. They engaged with the focus program, and the focus program showed them respect by saying, we're going to come to the home, and they kept those appointments. And when you have a team that's willing to go find families in trailer homes all over the community, or to meet them in a motel on Central in order to do the things that children needs. Parents understand that's a commitment. If the parents are having trouble accessing basic needs like food stamps or housing, the focus team helped them with the paperwork, or took them to appointments, or went with them to appointments to make those things happen. The main work of the focus team is to help parents meet the developmental milestones for their children. And so the ultimate goal of all this work is to try to put a child who has prenatal drug exposure on the right pathway to better developmental outcome, which means a greater likelihood of being able to compete in formal education. And we met the parents' needs by creating a medical home that solved parents for their medical care. We found parents do all sorts of things, take 3 buses to bring their child to medical appointments. And we were happy to see the kids given shots and stuff like that. But we realized that parents themselves, if they had a breast cancer, or they had cervical abnormalities, were not getting care. And we felt we would not be doing a good job if we gave the kids all their shots and they never got pertussis, but the mother died of an overdose, or the mother died of cervical cancer that could have been treated. So we needed to create a 2-generation medical model. And I think it's something that is not a challenge if people organize to do that. How do we reduce adverse experiences through the program? Well, we addressed safety for the mom and kids. If we identify a home where there is a violent partner, then there needed to be an important conversation about how you're going to provide for your own safety and your kids' safety. We provided anticipatory guidance to prevent neglect. And anticipatory guidance to prevent neglect is how do you handle when your child has a temper tantrum? How do you organize sleep time so that you're not so frustrated you're likely to shake the baby because the baby's crying? We created support for isolated parents to help their parenting by going to the home instead of making parents. In those days, the standard treatment was that a parent who is accessing early intervention had to figure out how to get their kid to an early intervention center for an hour of therapy and then go home. We decided it would be important to bring therapy to the home to try to meet their needs. And the focus medical team is available in clinic for both chronic and acute care needs. In our visits, we reviewed the parents' current alcohol and drug use, and we supported their efforts to achieve sobriety, but also talked about harm reduction efforts. And harm reduction is a little different model that has to do with how do you think about your substance use, what is it doing in your life, and how do you think about that in relation to keeping your child safe. We ultimately were able to begin to provide Suboxone medication-assisted treatment, part of the primary care medical home that has been revolutionary in terms of the ability to support parents who are trying to address opioid substance use. We began to manage depression directly for the mother. So instead of sending them to psychiatry or mental health care, we began to take on the management of depression, which results in much faster lightening of the mother's sadness and makes her much more available to the child. We began to take a large view of health beyond treatment of disease, but what is it that makes people healthy? How do we help a whole family achieve a better health status? And part of that meant that we had to address legal needs, that you are unlikely to have good health if you're being burdened by civil legal needs that don't seem to have a resolution. And to do that, we created a connection with the UNM clinical law program so that families have access to law students and faculty attorneys who can take some of their civil legal situations and find resolution. So going back to Ava, how did she make changes in her life? Well, she made a lot of changes in the course of her life. She completed treatment and actually was able to become drug-free. She completed her GED. She had a stable relationship with a father who came back from prison and accepted the child. And when I first met him, he would sort of sit in the corner of the exam room and not really make eye contact, and didn't really seem to want to do anything with the child. But as the team went to the home and showed him more and more about what Marcus could do, he got more and more into it. And ultimately, he was a guy who would get up in the morning with the child, make breakfast, get the kid dressed, get him to daycare while Ava was going to school. They got married. They both became active in church, which hadn't been real important to either of them before they began to get into recovery, and they both volunteer in the church now. which has provided a stable social connection as well as important child care. So in the last visit we had in 2016, Ava is now 23 years old, has gone from being a teen to a young adult. Well, Marcus is 6 years old. He's been healthy. He had some ADHD issues in kindergarten, and we had a long discussion about that. And they agreed to have him have a trial of medication. That seemed to make a big difference in his ability to stay regulated in the classroom. Now, part of it, it's a maturity issue, and my hope is that he gets more mature. He'll figure out his own brain and how to participate in school and how to interact with peers and not need medication. The father, in his recovery, became a lay minister, and they participate in ministry in homeless shelters and food programs. Ava entered a nursing program. Her big desire is to give back to the community, to give back to people because she had help. They were able to purchase a trailer, so they moved out of the family home and have their own place to live. And they've had 2 more children since Lamarcus was born, and neither child had exposure to drugs or violence in the home. And so this family had made this really, really great turnaround. And so we have now begun to think, going back to our layer cake schematic, about how we connect our intervention concepts across generations. On the left are the adverse experiences that Ava had, and on the right, the kinds of layers of experiences Lamarcus had: a brain altered by prenatal exposure to drugs, some adverse childhood experiences, the drug exposure, mother being depressed, father in prison. But because of the support that the family got, Lamarcus was beginning to show regulated neurodevelopment. Not perfect. He had some ADHD issues, ability to develop some social, emotional, and cognitive skills. And then with our hope is that over time we'll adopt healthier behaviors and have improved health-seeking status. And in the course of life, create the capacity to address stress in a tolerable way to lead to better outcomes. So collaborative interventions to reduce generational impact of adverse child experiences basically would put a block in between the transmission of these experiences in Ava's life to Lamarcus's life, and then Lamarcus, as he's doing better, transmits regulated neurodevelopment back to the parents, so that there's I really apologize about this. The parent is able to reduce health risk behaviors. And for example, Ava started school to have a nursing degree, a healthier status. And they're talking a lot about how to change the diet in the family home to reduce the risk of obesity and overweight, which is fantastic. And hopefully for both generations, a long-term healthier life. So that's really the concept of how we think that focus could begin to change the sort of layer cake model for a long-term family outcome. So that's the end of the presentation, and I would like to say thank you to all of you who are watching this for your dedication in working with families and thinking about how we together can put our arms around families at high risk and embrace their health needs, engage them, and potentially lift them to a higher health status.
Right. Thanks so much, Andy.
Thank you.
I think about, especially with the focus of this program, which would be, it's on the neonates in their very beginning,
Yes.
where they have that bottom layer of that cake where they have the risk of prenatal substance exposure. But then right away, that next layer of cake, there's adverse childhood experiences, which we can start working on limiting in this neonatal period by having the families be early engaged with their care providers in their community. And then right away is that third layer on the cake, which is the neurodevelopment. And so we know that the non-pharmacologic interventions we do for neonates in the very beginning already can start addressing those risks to the little brain that have been hit by the prenatal exposure. The brains are plastic. We can affect them right away by doing non-pharmacologic interventions in that neonatal period.
I think that's such a good observation that, the support of breastfeeding when it's possible to breastfeed, the care of the family and child in the hospital setting to begin to develop the kinds of learned patterns of response, the cue reading, the management of these potentially challenging situations. I agree with you so much that it begins to invoke the plasticity of the brain, may more quickly achieve homeostatic regulation of these neurotransmitter systems, so that mood and affect and sleep and learning and reward are all improved rapidly, which then leads to the greater risk of better chances of good development that would then lead to potential to do well in school.
Yeah, and the other piece that I really appreciate about this presentation is the emphasis on the positive effects of engagement, prenatal care engagement, and then after the baby's born with the family. And if we can engage them as a unit in all of these settings, then just simply being there for them as care providers can make such a big difference for them.
Yeah, I so much appreciate doing clinic with you because I see how families connect to you, and you've seen them in the nursery. You've managed the care of the baby who has been observed or been treated for neonatal opioid withdrawal syndrome, and the family comes to clinic and they see you and the baby knows you, and that continuity of care, that ability to engage in continuity of care has fantastic implications.
And it's quite rewarding as well.
So rewarding.
Yeah.
Yeah.
Well, thank you again.
Great. Thank you for inviting me.